So for the next talk, I was given a febrile patient with no neutrophils. It's basically an expansion of febrile neutropenia, right? So to understand both the definitions, that what do you mean by neutropenia and what do you mean by febrile neutropenia. So neutropenia is an absolute neutrophil count of 500 cells per cubic millimeter or less than 1000 with an anticipated decline to 500 cells within 48 hours. So either the first value has to be 500, or if the first value is 1000 but you expect it to go down to 500 within 48 hours, it would qualify as neutropenia. And when you talk about febrile neutropenia is when you have neutropenia and then you have a single oral or tympanic temperature which is greater than or equal to 101 degree Fahrenheit or 38.3 degree, or greater than or equal to 100.4, that is 38, for at least 1 hour, right? So this is febrile neutropenia. So first condition, you should have a neutropenia, and then certain numbers about fever. So why are we so worried about neutropenia? Basically, neutrophil is a specific cell type of WBC that plays an important role as the body's first line of defense, and they make up to half to two-thirds of all the white blood cells, and they protect against infections, specifically the bacterial infections. In addition to neutropenia, disruption of mucociliary barriers, extensive use of invasive devices, shifts in the inherent microbial flora, because you are giving prolonged antibiotics to this subset, it predisposes these patients to infection. So these factors plus neutropenia will shift these patients more towards an infective process. So how do you evaluate such patients? Always ask the history. That is very important for these patients. So previous such episodes, go through their case records, any associated localizing signs, look for their ear symptoms, nose, throat, respiratory, gastrointestinal, musculoskeletal or urogenital symptoms. What is the nature of therapy? What is the expected duration of neutropenia? Because that will tell you, is this chemotherapy cycles over or they will still go on? Any previous cultures, any exposure to multi-drug resistant bugs? What are the prophylactic antibiotics? Because that again will tell you, are these patients infected with a drug resistant bacteria or they are coming from a community? And what is the role of steroids? Are they on steroids or not? Physical examination, the golden rule for such patients is they may appear well despite in hemodynamic compromise, and so evaluate the vitals very carefully. They may appear up and about because neutropenia per se will not show classical signs and symptoms. And the sites which are missed are oral cavity, mucositis, ear, sinuses, perianal area, intravascular catheter insertion sites, sites of bone marrow aspiration. Patients have pus even at bone marrow aspiration. They may have a furuncle there. So look at those sites as well. The catheter insertion site, right? All erythema here. These are probable sites of infection and they are very prone for such sites. Look for their tongue. So possible sites of infection, if you are looking at eyes, they would have conjunctivitis or orbital cellulitis. When you look at the ear, nose, throat part, otitis media, very, very common. Otitis media is one of the most common presentations when you look at these patients who are on chemotherapy. Tonsillitis, pharyngitis, sinusitis. If they are being fed through a rice tube because of the issue with feeding, sinusitis has to be looked at. Dental caries and abscesses. Consolidation, diarrhea, dysentery, enterocolitis. Now enterocolitis is again a very important factor that these patients have. Perianal candidiasis, perianal abscesses, cellulitis, abscesses, furunculosis. Furunculosis is another factor. Chemotherapy would lead to hair fall, right? So they will tend to develop furunculosis, and this furunculosis becomes infected in these patients. Meningitis, meningoencephalitis, urinary tract infection, and when these patients are on any catheter, whether that is a central catheter, a tunneled catheter, or even a peripheral catheter, please look for the exit site infection. Once you examine this, try to stratify the risk. Where do you want to manage such patients? So risk categorization, it correlates to the kind of serious or the risk of serious medical complications, and this will determine the mortality in these patients. So you want to know whether I can manage this patient in an inpatient category or this patient goes as an outpatient category. What is the antibiotic choice? Will this patient be an oral antibiotic choice or an intravenous antibiotic choice? Then what will be the duration of antibiotic therapy? So this is how the risk stratification would happen. And what are the risk factors? What are the chemotherapeutic agents that this patient is on? Is this an advanced oncological disease? Is there a history of prior febrile neutropenia? No antibiotic prophylaxis or GM-CSF or G-CSF use, presence of mucositis, poor performance status and cardiovascular disease. These are independent risk factors for any patient on chemotherapeutic agents to develop febrile neutropenia. And so for risk assessment, the Multinational Association for Supportive Care in Cancer, the MASCC score was developed on certain factors, that what is the burden of illness, and is there hypertension, COPD, solid organ tumor, dehydration, outpatient status and age. So if the patient, and look at the symptoms, they are no. So the patient should not have this. So if the patient doesn't have this, it means the score should be on a higher side. So a score of more than 21 indicates low risk. Remember, in most of the studies, higher score means higher severity. Here, higher score means lower risk. And this is how you would categorize. So you would calculate these scores, and if the score is less than 21, these patients classify as a high risk patient and they have to be managed as inpatient. They would require broad spectrum intravenous antibiotics. If the score is more than 21, they are low risk. They would go on an oral antibiotic. They can be managed as outpatient category. So the management plan would be, if the patient has febrile neutropenia as per the definition, you do your clinical assessment and look at the MASC score. If it is less than 21, that is a high risk category, he becomes an inpatient category. If this patient has hypotension, pneumonia or other supports, he would land up to your ICU, and if that happens, you would investigate him further. And when you talk about investigation, the basic panel that goes for all neutropenic patients would be complete blood count with absolute neutrophil count, renal and hepatic function, coagulation profile, blood cultures, 2 sets preferably before administering the first antibiotic, urine analysis and cultures, sputum microscopy and culture, stool microscopy and culture, chest x-ray, CRP and procal. And this is the first set that you would send, and you would start an antibiotic. Now if the patient doesn't respond for next 48 to 72 hours, another test would happen. And first test that we say is HRCT, and this is only if the pyrexia doesn't settle after 72 hours of antibiotic therapy and bronchoscopic alveolar lavage. There are certain indications when to do and when not to do. So for all neutropenic patients, the first empirical antibiotic choice would be an anti-pseudomonal beta-lactam agent, right, for all high-risk patients with neutropenic, and this is grade 1A recommendation. So they would be either a carbapenem or a piperacillin tazobactam. Add aminoglycoside if this patient is having hemodynamic instability, and any glycopeptide, whether it is vancomycin or teicoplanin, or if you want to look for dactomycin, they should be added when you are looking either for an MRSA infection or a central venous catheter exit site infection. So what we call as catheter related infection, CRI. So look for vancomycin or linezolid or teicoplanin or dactomycin. Polymyxin B, colistin, tigecycline when we are looking at KPCs, right? When the local flora of your hospital is such that almost all bugs turn out to be KPC, start these antibiotics as the empirical. But remember, the grade 1A recommendations are only for 2 antibiotics. One is an anti-pseudomonal beta-lactam agent and vancomycin when you are looking at suspected catheter related infection. Because of the risk of nephrotoxicity, teicoplanin is the second choice. Then certain specific subsets with febrile neutropenia, and that is acute respiratory failure. Almost 50% patients will have respiratory failure, and there is a mnemonic which is by the name as DIRECT, and this would tell you what is the risk factor for acute respiratory failure. So D stands for delay since the start of antibiotic prophylaxis once the diagnosis of cancer has been made. What is the immune status of this patient? What is the radiographic appearance of this respiratory failure? Look at the literature, look for the knowledge, how does it look like, try to compare the images of your radiograph versus the radiograph which is there in the literature. What is the clinical picture, as in what is the ongoing chemoprophylaxis, what is the prophylactic antibiotic cover that you are giving to this patient, and findings on HRCT scan. So HRCT, so this would tell you about the type of respiratory failure that you are looking for. Now when we talk about fiber optic bronchoscopy and BAL, basically this is one of the earliest tests that has to be done in almost all febrile neutropenic patients to have a relevant culture. But the problem with this is that this may even push these patients from a non-intubated state to an intubated state. They are very, very prone for this. So it has to be done not as a blanket rule, but again case to case basis. Second, NIV. We always say that for immunosuppressed patient, prolong NIV, right? But there have been studies specifically in neutropenic patients which have shown that NIV unnecessarily prolongs or delays intubation, and it has resulted in increased mortality. So NIV has to be very cautious that if the patients are not tolerating on certain cycles of NIV, please shift them to an invasive ventilation. When you talk about ARDS specifically, and these patients are neutropenic, the administration of GM-CSF or G-CSF has been associated with increased incidence of ARDS and increased mortality, and this is specifically when we are talking about severe ARDS condition, that is PF ratio of less than 100. So for ARDS risk, and when there is severe prolonged neutropenia, we have to avoid GCSF. So let the neutropenia count be less than 500, and if there is ARDS, do not administer these drugs. Then central line related. If the patient has an IV catheter, the catheter related infection should be suspected. Differential time to positivity of 2 hours should be taken as a benchmark. So you're drawing a sample from the central line, you're drawing a sample from the peripheral line, and the central line beeps 2 hours before the peripheral culture, that is taken as DTTP, and this is highly sensitive and specific indicator of catheter related bacteremia grade 1A. The drugs vancomycin or ticoplanin should be given to cover gram-positive infection. Now, removal of the line should be considered only in certain cases when you are looking at tunnel infections, pocket infections, patients having continuous bacteremia despite your adequate antibiotic. Now, even a central line, even if it turns out to be positive as per your differential time to positivity, and the patient is clinically hemodynamically stable, there is no hardcore indication to take out the line. You can administer your gram-positive cover, leave the line there, and you can monitor the clinical response. If the patient does better, don't remove the line. Secondly, for central nervous system related catheters, the shunts, you can administer the drugs and there is no hardcore evidence of removal of the line. But if there is persistent bacteremia despite doing all this, remove the line, and if there is a need for a central line, put it at the other side. Then neutropenic enterocolitis or typhlitis. This is a life-threatening condition, and if you have to diagnose it, basically there are certain clinical signs and radiographic signs. So clinical signs would be fever and abdominal pain, and when you look at the scan, whether it is an ultrasound or a CT scan, the bowel wall thickening of more than 4 mm in a transverse and 30 mm in a longitudinal scan is diagnostic of this. What is the therapy? Therapy is conservative. Put in a Ryle's tube, give them TPN, get them adequate fluid cover. They tend to bleed. Patients will have an upper GI or a lower GI bleed. Correct their coagulopathy, give them blood transfusions, fresh frozen plasma, platelets as and when what is required. So conservative treatment has shown to have a mortality benefit as compared to early surgical intervention in this group. But still, if conservative treatment fails, there are certain indications which are persistence of GI bleed despite correction of your coagulopathy, free air which suggests that the bowel has perforated, clinical deterioration despite your medical treatment, and if the patient develops nematosis, which is almost pathognomic for bowel ischemia, and this is an emergency situation where you will have to rush these patients for surgical intervention. So this is the same management plan as I discussed. All these patients will eventually require broad spectrum antibiotics and plus minus antifungal therapy. I'll tell you when to add antifungal therapy. Then about these agents which you give in neutropenic patients, three choices: GCSF, granulocyte transfusion, and intravenous immunoglobulin. None of these studies have shown any clinical benefit of outcome when you're talking about nosocomial infection, that once you increase their count by 1000 by giving GCSF, the nosocomial infections would go down. None of these studies or meta-analysis have shown that. And remember, in severe ARDS, do not administer GCSF. Granulocyte transfusion therapeutic administration in the neutropenic host with severe infection has not shown any benefit at all. Intravenous immunoglobulin, no benefit has been seen as of now when you're talking about febrile neutropenic patients, and there has been no decrease in the nosocomial infections. So when do you reassess? You reassess at 48 hours, right? And when your patient is falling, he has become afebrile, the ANC has improved, and then you again categorize, is it a low risk or a high risk? If this is a low risk patient, you can consider this patient to be discharged and continue on oral therapy. But if the patient is high risk and you have not been able to identify an agent, remember that there has been no pathogen which has been identified, stop aminoglycoside. Aminoglycoside has to be stopped at 48 hours if you are not identifying any pathogen. But if you are identifying a pathogen, give antibiotics as per your culture sensitivity. But if the pyrexia continues at 48 hours, then look for certain other things. Either you start you continue the same therapy, or you seek the help of a microbiologist to know is there anything else which is growing. So when do you look for antifungals? The IDSA says that empiric antifungal agent should be started after 4 to 7 days in high risk neutropenic patients who are expected to have a total duration of neutropenia of more than 7 days and who have persistent fever and in whom the reassessment does not yield a cause. So when the reassessment did not yield a cause, we stopped aminoglycoside, right? And after 4 to 7 days of total neutropenia, we started antifungals. And the choice should be on the which bug are we looking for, which bug are we suspecting, and that should determine the choice of antifungal. So if the patient has never been exposed to an antifungal, fluconazole is the choice of antifungal. Patients with prior exposure, echinocandin. The European guideline says for all patients echinocandin, whether they have been exposed or they have not been exposed, but there are certain differences between other guidelines. When you are talking about any hemodynamically unstable patient and you are thinking of adding an antifungal, echinocandin. Patients with pulmonary infiltrates, because you are suspecting aspergillosis, voriconazole or liposomal amphotericin B, and if you are suspecting mucormycosis, again liposomal amphotericin B. What should be the duration of therapy for all febrile neutropenic patients? And you can divide them into three scenarios. The first scenario is when the ANC has improved, patient is asymptomatic and has been afebrile for 48 hours, the blood cultures are negative, antibacterials should be discontinued. The scenario 2 is the ANC is still less than 500, patient has suffered no complications and has been afebrile for 5 to 7 days, antibacterials can be discontinued except in high risk cases with acute leukemia or following high dose chemotherapy, when antibacterials are continued up to 10 days or till the time ANC improves to 500. The third scenario is patients with persistent fever despite the neutrophil recovery. You probably need to add an antifungal over and above whatever you are giving. So the take home points for all neutropenic patients, it's a life-threatening complication. Hemodynamically unstable patients and those who develop respiratory and other organ dysfunctions are at increased risk of complications and they would require ICU admission with very high mortality. Careful assessment and prompt initiation of appropriate broad spectrum antimicrobial therapy should be initiated, and local microbiological data always have to be in consideration whenever you are initiating your therapy. So these are the 2016 guidelines, right? Management of febrile neutropenia, ESMO clinical practice guidelines, which talk about all this. And in 2014, how to treat severe infections and critically ill neutropenic patients, the another landmark paper about how to do it. So these are the two papers one should go about whenever we are thinking of neutropenia. Thank you.